Hello, students. Today we're going to talk about medications for Parkinson's disease and medications for muscle spasms. I'm going to share my screen and we will start. And I will do a slideshow, play from start. Okay. So we have different degenerative diseases of the central nervous system, including Alzheimer's disease, ALS or Lou Gehrig disease, multiple sclerosis, and Parkinson's. For the purpose of our course, we will be focusing on the Parkinson's disease. I will briefly talk about Alzheimer's, but you don't need to remember the medication for Alzheimer's. I just want to bring up something to your attention that I think is important. So Parkinson, most common degenerative central nervous system disease, and the physiological cause of the disease is the loss of dopamine in the brain. And as a result of the loss of dopamine, there is abundance of ACH. And so we will be using medication to manage the symptoms of Parkinson's, which either increase dopamine or have anticholinergic effect. So what are the symptoms of Parkinson's? The main symptom to diagnose Parkinson's disease is bradykinesia. And it's a weird word. Brady means slow, right? Bradycardia is low pulse. But bradykinesia is slow movement. But it's actually not necessarily even slow, it's just lack of coordination of movement. And what people start experiencing is that they cannot start walking. It's as if their body forgot how to make a step. They would just try to make a step, and it will be a while until they will wheel their body to make a step. It looks very weird. They might have difficulty chewing and swallowing. They might have difficulty speaking in what looks like spasms of the vocal cords. So everything that is kind of movements become weird. It's in Parkinson's disease, it's called bradykinesia. So when the neurologist is making a diagnosis of Parkinson's disease, they ask the patient to do some fast repetitive movement, like tapping the foot or bringing the thumb and the middle finger together in repetitive fast movements, like you're opening and closing the beak. And so they will see that the patient might start doing it fast, but then they can then they slow down and they become the movements become non-rhythmical. So this is again the number one thing that has to be present to diagnose Parkinson's. You also often have tremors. Sometimes tremors are the first sign of Parkinson's, and sometimes we don't know whether it is an essential tremor, meaning it's just a tremor, or it is a first sign of Parkinson's. What happens with the Parkinson's disease, there is actually quite a long period when there is already a decrease of dopamine in the brain, but we don't really see symptoms yet. We actually start seeing symptoms when we have only about 30% of dopaminergic function left in the brain. Okay, so but tremors tend to be early symptoms in a lot of people. And it's very interesting. It's tremors at rest. So the person would be sitting and you would see that they're doing these small movements with the fingers, like they are counting money type thing. But when they try to grab a glass, the tremor disappears, as opposed to essential tremor, which tends to be more a tremor with movement. So anyway, the tremor with Parkinson is tremor at rest. Muscle rigidity, which a lot of time, it's not very common for people to complain about muscle rigidity. But again, when neurologists will do the testing of the muscles, that's one of the things that they will notice. As the disease progressing, muscle rigidity does become more of an issue and is often a complaint that people have. Postural instability, and that's very scary because people with Parkinson will fall, not necessarily like in a predictable direction, but basically they just lose balance and fall in any direction. And another interesting effect is like their facial expression becomes blank. So that flattening of the effect. The health problems in Parkinson's patient affect the muscle movement, but they also can have autonomic nervous system disturbance, such as constipation and difficulty urination. They can sleep disturbances. Interestingly enough, very vivid dreams or acting out their dreams in the sleep, the lack of paralysis during REM sleep is one of very early symptoms of Parkinson's. Okay, and then with time they can develop anxiety and depression. So physiologically, basically, there is a degeneration and destruction of dopamine producing neurons in the portion of the brain called substantia nigra, which is basically translated from Latin is black matter. When they were doing the autopsies of patients, they did notice that there is a degeneration of this area, of this black area in the brain. And later on, they realized that it had to do with dopamine production. There is also some involvement of corpus striatum in terms of dopamine stimulation on corpus striatum. Will be the cause of the unconscious muscle movements, and we'll talk about it a little bit later. So, as I mentioned in the beginning, we have the problem with the balance of neurotransmitters. We have the absence, the decrease of dopamine that affects the balance, posture, muscle tone, and involuntary movement. But on the other hand, the absence of dopamine allows acetylcholine stimulation. You might remember that when we have a patient with psychosis, it is believed that the symptoms of psychosis are caused by overstimulation of dopamine receptors in the brain. So a lot of antipsychotic medications work by blocking dopamine receptors. So the side effects of dopamine receptor blocking can be Parkinson-like symptoms. And in this case, we don't call it Parkinson-like symptoms, but we call it extrapyramidal symptoms, but it is basically very similar to Parkinson. And they include dystonia or muscle spasms. Some patients actually feel locked up, they cannot move. Restless movements, remember like how I said that patients with Parkinson's can start having this weird tremor and weird movement. And the most uncomfortable one is called tardive dyskinesia, which is what looks like tics, involuntary movements of jaw and face. So again, this is extrapyramidal symptoms. And when we talk about anticholinergic medications that we use for Parkinson's symptoms, for help with Parkinson's symptoms, especially tremors, you will see that Congentin is a medication that you will see used a lot in psych wards. So it's almost automatic. In psych, they will put somebody on antipsychotic. The next thing that person has is a person develops a tremor, and they will put them on Congentin exactly the same way as we put Parkinson's medications on Congentin for control of tremor. This is a nice picture from your textbook that talks about the symptoms of Parkinson's and what's happening in the brain and what medications we are using. So we kind of, it just brings together everything we just talked about. Okay, so if we want to increase dopamine in the brain, how can we do it? Well, the simple answer would be give patients some dopamine. You might remember that we use dopamine in treatment of shock, right? Unfortunately, giving somebody even IV dopamine will not do us any good for Parkinson's because dopamine does not cross blood-brain barrier. Oh, before I talk about treatment, what we need to understand that all the treatment we have, all the therapy we have for this condition is a symptom of is the treatment of symptoms. Unfortunately, at this point, we cannot treat the cause of the disease. We cannot eliminate the disease, unfortunately. We only can treat symptoms. We only can make the life of the person with Parkinson's disease more manageable, managing symptoms, right? Unfortunately, early treatment does not improve outcomes in the long term, but it does not make things worse. You probably heard that as with any progressive disease, the symptoms become worse and worse in time. And you sometimes hear patients saying, oh, I don't want to start treatment. I want to save it for when it gets much worse. Well, unfortunately, all treatments we have at this point work best in early stages. And no matter whether we start treatment after 2 years of Parkinson's or after 4 years of Parkinson's, by 6 to 8 years, we do expect worsening of the condition and the treatment not working as effectively. Okay, so again, we are only managing symptoms. So we cannot just give dopamine because it does not cross the blood-brain barrier. What we can give is a precursor to dopamine called L-DOPA or levodopa. The problem with just giving it is that it gets transformed into dopamine really quickly in the periphery, in the body, before it has a chance to reach the brain. So if we just give somebody levodopa, the person will have very mild effect because, again, only 1% will be available to the brain. That's why we mix levodopa with something called carbidopa. And what that carbidopa does, it does not cross blood-brain barrier, but it kind of blocks the receptor that would transfer levodopa into dopamine in the periphery. So the levodopa doesn't get used, so more levodopa is available for the brain to be converted into dopamine. Okay, levodopa is an active agent. Carbidopa just makes levodopa more available. Kind of similar to when we talk about antibiotics and we talked about beta-lactams, right? With for augmentin, your amoxicillin is your active, active antibiotic, and shelvonic acid prevents the destruction of amoxicillin by the penicillinase enzyme. So there's the same idea that it makes more levodopa available to the brain. We also can we can also give direct dopamine agonists, which is not dopamine, but it has similar effect to dopamine, okay? And you don't have to remember these medications by names, but what is really important is to think about what are the effects of dopamine on the brain. Dopamine is a reward hormone. I mean, like neurotransmitter, not a hormone. It's a reward neurotransmitter. There is a very interesting experiment when people of different ages were playing computer games when and the MRI, the functional MRI, was tracking the activity of their brain. In young children, any award they're getting, no matter how small the award is, will cause very significant a very significant production of dopamine by the brain. So that's why with toddlers, you can give them a sticker and they will do anything you want for a sticker. For adults, the amount of dopamine released by the brain is proportional to the reward. If you give an adult a sticker, they will not be very enthused. But if you give an adult like $100 check, they will get much more dopamine in their brain. Okay? In teenagers, it's really bizarre. And in teenagers, almost nothing gets dopamine release. Okay? No matter you give them $100, they cannot care less. What gets dopamine released is when they do something dangerous, and especially if their peers are watching them. That gives them a huge release of dopamine. Okay, so that basically explains teenage behavior. Okay, so what happens? So dopamine is that reward neurotransmitter. And when we give especially direct dopamine agonists, patients become more reckless. They kind of become like teenagers. And so in some patients, they develop about, I think, 20%, some pretty significant, no, 15, I think, 15% of patients, I think, develop compulsive behaviors, compulsive shopping, compulsive gambling, right? Gambling is big dopamine producing activity, and compulsive sexual behaviors. And when I have in my class, when I have CNAs who work in skilled nursing facilities, they will say, oh, yes, we know to watch for our older patients on direct dopamine agonists. They start doing teenage things, reckless sexual behaviors. Okay, so that's a very, very important patient teaching, because I actually know a family that lost all their possessions because the wife did not realize that the husband started gambling from being he never gambled until he was put on direct dopamine agonists for his Parkinson's. Okay, then we have indirect agonists, and indirect agonists work by blocking the enzyme or inhibiting the enzymes that break down dopamine. And some of these, so there are two groups, and one is MAO inhibitors, specifically MAO-B inhibitors, and Ezelect is what you see quite often. And you might remember from our cholinergic medication, adrenergic medication lecture, that you need to be really careful with MAO inhibitors, and that giving foods that are high in tyrosine, like aged cheeses and wine and smoked meats, can increase the effect of these medications and bring too much dopamine and too much norepinephrine and have adrenergic crisis. Okay, so we either have MAO inhibitors or we have COMT inhibitors, which is a different enzyme that is a little bit more specific, I think, for dopamine. And so what will be our prototype medication is actually a combination of levodopa, carbidopa, and a COMT inhibitor, entacapone. Okay, so levodopa is your acting agent. Carbidopa prevents it from being used on the periphery, and entacapone blocks the enzyme that destroys it at the synapses, and so dopamine is available for a longer time. So as I said, this is our Stalevo is our prototype drug, and it increases the availability of dopamine and restore dopamine function. And so you have, again, the same uncontrolled or purposeless movements, involuntary movements, again, just like the extra pyramidal. No, I'm sorry, I'm saying something wrong. So uncontrolled purposeless movements, and these agents are contraindicated in narrow angle glaucoma. So the function of the medication is relieving some of Parkinson's symptoms, especially tremor, bradykinesia, gait, and muscle rigidity. It takes a couple of months to have the full effect. We cannot do abrupt withdrawal of this medication. This is important for both my exam and NCLEX, so no abrupt withdrawal. You need to taper it down, and your adverse effects is uncontrolled and purposeless movements and muscle twitching. This will be on the test. Muscle twitching and winking are early signs of toxicity. You can have orthostatic hypotension, and you can develop psychosis. So this definitely sounds kind of scary. And unfortunately, and that's one of the reasons why a lot of patients delay the use of this medication because of the adverse effect profile. Psychosis is very specific. They have a very specific ideas which medications to use and what not to use with Parkinson's psychosis, and you'll probably talk about it in your psych class. For us also, orthostatic hypotension in general is a very important side effect in all patients for the nurse to know, because patient can fall. And it is contraindicated in history of in patients who are treated for narrow angle glaucoma, because we don't want to increase the pressure in the eye. And it does interact with many medications, and we do need to avoid antacids, and we need to take the medication on empty stomach. Again, that's another very important thing for the test, that levodopa carbidopa should be taken on empty stomach. It can cause elevation of the liver enzymes, and okay, I think that's the last slide. Okay, so this is our most effective medication for controlling symptoms of Parkinson's, but again, it also has most adverse effects. As I mentioned before, we can have other medications that have dopaminergic effect. I mentioned Requip, which is a dopamine agonist. Tasmar is similar to Encapone, that it inhibits breakdown of dopamine. And there is another one that cause dopamine release from nerve terminals. Unfortunately, all these medications tend to work in early stages of Parkinson's, but at the end, there is basically such a loss of dopamine producing cells that no medications really help very significantly. No medication eliminates the symptoms. Let me see if, so I'm sorry I didn't put it on the slide, but it's another very important concept that we see as Parkinson's disease progresses, is that patients have a lot of on-off symptoms or worsening of the symptoms when it's getting closer and closer to the next dose of medication, right? So when we give somebody a dopaminergic agent, whether it is Sinemet, which is levodopa carbidopa, or Requip, which is dopamine agonist, it works for a couple of hours, and then people start feeling the decrease of dopamine again. So especially again with Sinemet, we end up giving this medication close and closer together. So we are decreasing the interval between doses. And so now, this is not for the test, but just for you to know, there is actually surgical intervention when they implant a dopamine releasing pacemaker in the brain that they use especially for younger patients with Parkinson's, that need to go to work, and so still need, I mean, if your patient is like 80 years old, a lot of times they're afraid to do a surgery, but if it's somebody who is younger, they actually, again, implant something in the brain that releases dopamine. There is also, I think, the medication that being developed that is kind of a dopamine pump, like the same as similar to what we have for insulin pump, but we are not as close. We are not definitely close to having that in mass, like widely used. Okay, so let's talk really briefly about anticholinergic agents. And these are centrally acting agents that block acetylcholine, just because, remember, when we have the drop of dopamine, the acetylcholine takes the opportunity to be more active, and some of the symptoms of Parkinson's can be improved by administering acetylcholine blocking agent. And our prototype drug is benztropine oxygentin, and it is a centrally acting cholinergic receptor blocking. And this medication suppresses tremors, but it is not helpful with other symptoms of extrapyramidal antipsychotic medication, as we discussed it. Okay, we need to take benztropine quite often, sometimes 4 times a day, depending upon the severity of the symptoms. And as you can expect, benztropine can cause typical anticholinergic side effects, such as dry mouth, constipation, and tachycardia. And it interacts with everything under the sun, almost like Coumadin. And it is contraindicated in, again, our favorite disease, narrow angle glaucoma, but also remember that it blocks acetylcholine. So somebody who has a disease, myasthenia gravis, which we are not covering in pharmacology, but it's basically a disease when the patient doesn't have enough acetylcholine, and that causes profound muscle weakness. You will have this medication, by blocking acetylcholine, will worsen myasthenia gravis. We want to avoid over-the-counter cold medication because it increases the peripheral dopamine effect. And the treatment of overdose is that cholinergic agent that we discussed in our cholinergic medications lecture, physostigmine, which we always use for the treatment of anticholinergic intoxication. When we teach patients about dopaminergic medications, important to tell them to increase fiber and fluids. Again, I'm sorry I didn't put it. Levodopa, carbidopa should be taken on empty stomach. They should avoid food and drugs high in pyridoxine, and they cannot abruptly stop these medications. For anticholinergic, take care of anticholinergic side effects such as dry mouth. The anticholinergic actually is taken with food or milk, as opposed to levodopa, carbidopa that needs to be on empty stomach, and it can cause, because it's anticholinergic, it will open the pupils of the eye, so we want to tell them to avoid bright sunlight. Remember, similar to atropine. So anticholinergic, our prodrug medication was atropine. Okay, and what the only thing I want to tell you about Alzheimer's disease is it's another progressive disease, and what is important is that the pharmacotherapy for Alzheimer's disease, interestingly enough, is cholinesterase inhibitor. So again, this is a medication that inhibits the enzyme that breaks down acetylcholine, increasing the amounts of acetylcholine. So basically, your worst combination, if somebody has both Parkinson's and Alzheimer's, right, and because they're completely different diseases, it's very possible that as we get older, we can get both. And then you're completely stuck because you would want to treat Alzheimer's with increases the amount of acetylcholine, preventing its breakdown, but you also want to decrease the amount of acetylcholine to control Parkinson's symptoms. Okay, so that would be very sad that we would not be able to effectively treat it. Okay, and this is the end of the Parkinson's lecture, and I will have a separate lecture on muscle spasm medications. Okay, bye guys. Stop share. Stop